Welcome to part 2 of the EoE Patient Journey Education Program. This is the second in a 4-part series, and we're joined again by Dr. Claire Beveridge of the Cleveland Clinic. Thank you so much, Dr. Beveridge, for joining us for part 2 of our webinar series on EoE. This is so exciting. We had a great first webinar series with you talking about symptoms of EoE and getting, if you're not diagnosed, what you need to know. And now we're going to move on to a really important piece of this series. What happens once you are diagnosed? Once you got that official diagnosis that you have EoE, what comes next? But first, for those of us who may be starting with this webinar, I want you to just summarize what EoE is again for us, please. Thank you.
Absolutely. And thank you so much for having me on. So just to summarize in terms of what eosinophilic esophagitis is, this is an allergic condition of the esophagus. It is often triggered by food or environmental allergens. It can be either of them. And when you get those allergens, it can cause eosinophils to accumulate in the esophagus. And eosinophils are these white blood cells that are normal to be seen in our body, but aren't normal to be seen in high levels in our esophagus, okay? So when we see those high levels in the esophagus, it can cause inflammation there. And when that inflammation remains uncontrolled, it can lead to scarring. Kind of the classic symptoms of that will be difficulty with swallowing, where we feel something gets stuck or slowly move down, can be heartburn, but maybe you have some nonspecific symptoms like abdominal discomfort, nausea, picky eating, some coping mechanisms with eating. So that's kind of big picture of what eosinophilic esophagitis is.
Yeah, and if you need more information, please go back and listen to part 1 of the webinar series. Dr. Beveridge does a great job and has some nice visuals about what EoE is. So what happens when I go to my doctor and I find out I have this, and what can I expect? Is there a medication I take? Do I have to watch my diet? Like, what happens? And maybe again, if you could just, divide it up between, pediatric and adult, that would be very helpful.
Absolutely. So in the last webinar, we kind of talked about, in your first visit, when you may be suffering in silence, aren't diagnosed yet, we kind of talked about that your doctor is going to be asking you a lot of questions, maybe talking through what different diagnoses they may be thinking of. Typically, when I have someone come back with me, maybe they have already been diagnosed and it's their first visit, or maybe I finally diagnosed them. This visit, I spend a lot of time counseling them. So it's a lot of time telling them about what eosinophilic esophagitis is, what the different treatment options are. And then at the end of the day, it's, what is the patient's choice for what the treatment should be. So when we have the inflammation, we want to control the inflammation because we don't want it to turn into scarring, because when there's scarring of a tube, which is the esophagus, that's then going to narrow down and we get those rings, strictures, narrowings that can happen. And once we start getting some scarring, it can be irreversible. So we want to try to prevent scarring from happening or prevent worsening scarring from happening. I also talk with my patients about how, there's no cure. I can't give you a dose of penicillin and you're done, but it is treatable. Okay. And I think about it in terms of, 2 main buckets, that we have the food elimination bucket or we have the medication bucket. And we'll go into more depth on what those 2 different options may be. And then I also like to set the stage that, unfortunately, follow-up endoscopies are needed to make sure that the treatment is working. So just like we can't rely on symptoms to diagnose eosinophilic esophagitis, we unfortunately can't rely on symptoms to know if treatment is working. So it does require a repeat endoscopy with biopsies to see if those eosinophils are in control or not.
So whether you decide to go the medication route or the diet route, you still have to have those. And how many, is it 3 months, 6 months, a year? Like, how often does the patient have to go through those endoscopies?
Yes. So, it depends on which treatment you pick. If you pick a diet elimination, and again, we'll talk a little bit more about that in a second, we generally repeat an endoscopy after 6 weeks. But a diet elimination generally requires eliminating 6 major food groups. and then reintroducing food groups every 2 to 4 weeks to see what your trigger may be. So that can be a lot of endoscopies. And some patients may decide, A, that's just going to be really, really hard for me to avoid a food group. B, I don't want to get that many endoscopies. Now, there are alternatives for doing it. We can only eliminate a couple of food groups to minimize the number of endoscopies, but it is to be aware that generally an elimination diet requires more endoscopies than the medication route. For medications, typically it's after 8 to 12 weeks of being on the medication, but we're not always sure that a medication or an elimination diet is going to work. So if it doesn't work for you, well, then we need a pivot, and then you're going to need another endoscopy. Or if there are any changes to medications, like you decide you want to wean down on the dose, you're going to need another endoscopy to make sure it's still working.
So if I was a patient, what would my options be, first of all, for medications? And again, this is no one size fits all. So what you may hear here from Dr. Beveridge, it may not be exactly for you. So that's why it's so important, right, Dr. Beveridge, to talk to your provider on your specific health condition and your overall health
condition. It's definitely a shared decision making. There's no one right answer. You got to kind of look at the big picture and what's going to work for you as the patient. So the different treatment options. So when we think about the medications, we have proton pump inhibitors. So that's medications like omeprazole, pantoprazole, those kinds of medications. That works in about 50% of patients. The two ways that we think it works is, number one, it kind of works directly on the inflammatory pathway. Number two, we all know that proton pump inhibitors are frequently used for reflux. And there may be a component to, well, if we control the acid from coming back up into the esophagus, then we're kind of keeping that barrier strong in the esophagus and not letting as many allergens through. Okay. Great. So that works in about 50% of patients, but not everyone. And then we have the topical steroids. We unfortunately don't have FDA approved medications specific for EoE formulations. So we jerry rig asthma medications to make it work. Specific formulations are in the pipeline. They will come. We just don't have them yet. So generally, it's either you swallow a mist from the Flovent inhaler, or you use budesonide and you break open these respules, you mix it with, Splenda or honey or applesauce, something, and then you swallow that, with the point being that it's supposed to coat the inside of your esophagus, just as like you would use a steroid cream on your skin. We're kind of using a steroid mist or slurry on your esophagus to calm down the inflammation. That can work in about 60% of patients. We don't think it causes any systemic effects. It can cause a yeast infection of the mouth or the esophagus in up to 20% of patients. So you should talk with your doctor about, how you take it, rinse out your mouth, other things to kind of minimize the risk of getting a yeast infection. Then there is dupilumab, which is a weekly injectable medication that has been approved for other allergic conditions and recently got approved for eosinophilic esophagitis. They just recently published their phase 3 trial data, and it looks like it works in about 60 to 80% of patients. So, if you're someone who has really bad seasonal allergies, really bad asthma, that's also related to eosinophils, it may be a really nice option for you. Or, you have eczema, other allergic conditions that it may be able to help treat as well. Some of this may be insurance coverage. We're seeing insurance covering it more and more, but it may not be covered by your insurance. It's also something that's a weekly injection, right? So not every patient likes the idea of having to inject themselves every week with something. There can be, a 20-25% risk of getting a local irritation where you inject, and also a risk of getting, colds or viruses.
Now, can that be used in pediatric patients as well, or is it just for adults?
I believe it's over the age of 12 for pediatric patients, and they have to be a certain weight as well. And then the other medications can definitely be used for pediatrics or adults. I'll say typically for diet elimination, so I can talk a little bit more about that as well, where, I kind of have written down for you, what the 6 major food groups can be in terms of what we eliminate. So we have dairy, wheat, eggs, soy, peanuts, tree nuts, seafood, and shellfish. Some in the Spanish data, they will also exclude all legumes sometimes. Here in the United States, we normally only exclude peanuts as our legume, and we don't also exclude, lentils, beans, and other things. But that can work in about 80% of patients when you eliminate all of those 6 major food groups. Most patients have 1 or 2 food triggers, the 2 most common ones being dairy and wheat, and especially in the pediatric population, the most common one is going to be dairy. So it's quite possible that, if your child gets diagnosed with eosinophilic esophagitis, it may be brought up of, why don't we just eliminate dairy and see if the eosinophils are controlled that way or not?
Well, that's a really good point. And I want to bring up the dietary management. You have to be very on it. Like, you have to be very vigilant, correct? And there are different things. You don't have to eliminate everything at once, right? And do you recommend to your patients that they work with a dietitian, or do you give them like a cheat sheet on what to do? Because you stop eating, say, milk or dairy, then you eat everything else and you kind of see what happens, right?
Yeah.
But then you would have to get an upper endoscopy, or is there anything that we can tell that we're feeling better? Like, this is the caveat, right? It's like,
yeah, you need the endoscopy. Yeah, you can't just do it. And some patients will feel better when they eliminate certain foods, but it doesn't control their eosinophils, right? Just because, maybe they have some lactose intolerance, maybe they have, some IBS. So eliminating some of these things may make them feel better, but it's not actually correlating with their eosinophilic esophagitis.
Can you do both? Can you do diet and the medication, or do you recommend one or the other? You have to do one or the other, something like that.
So in my practice, I don't like to mix and match, because then I don't know what is working. Now, there'll be patients where we've tried things and sometimes we need to do a combination, and that will get their eosinophils under control. But my first line is really to pick one treatment or another, and not try to mix it, because just as we were talking about, if we ever make a change to treatment, then we need to repeat an endoscopy and make sure eosinophils are still controlled. So I never want to put someone in the situation where, maybe they decide, oh, I do want to eat seafood again, but then they're going to need an upper endoscopy to make sure it's still controlled. So I counsel my patients to pick one treatment or another. We can always do combination later if needed. But in terms of your question and for, how we do the elimination diet, so there are different methods and ways of doing it. The traditional approach is to eliminate all of those 6 food groups, do an endoscopy after 6 weeks and see if the eosinophils are controlled. If they're controlled, then you reintroduce a food group every 2 to 4 weeks to see what your food trigger may be. Every endoscopist is going to be a little different, so you'll talk with your gastroenterologist, but typically it's reasonable to reintroduce 2 food groups at a time, except I like to do dairy and wheat separately, because those are the 2 most common ones. Now, since dairy and wheat are the 2 most common ones, there's also good data to say, let's just eliminate those 2 to start with. We only eliminate dairy and wheat. Maybe this will minimize the number of endoscopies you need to do in order to figure out what your trigger is. So the full 6 food elimination diet works in about 80% of patients. Doing the 2 food works in about 45% of patients. So that's pretty good. You're capturing a good number of patients with only eliminating those 2. If the eosinophils are controlled, then you reintroduce those, one at a time to see if one or both of those are your food trigger. If it doesn't work, then you can expand out and do a 4 food elimination diet or the full 6 food. Again, good data for the pediatric population of only eliminating dairy. I can't give you percentages. I don't know that off the top of my head. I don't think that there's been data looking at adults for dairy, but definitely for pediatrics. So sometimes they'll do the 1 food elimination diet with only dairy.
Well, this is very interesting. You've given a lot of food for thought, no pun intended, for our listeners. And I want to talk a little bit about long-term management, the reality of living in a world when we're so busy, everything's processed food and we're on the run, eating out, traveling, kids going to school. Like, what do you tell your patients, especially your younger patients or the parents, how to manage this for a child who's got to go to school, or, someone that's traveling a lot, a college student? Like, what do you tell them?
What I tell them is what you pick today doesn't have to be your forever treatment. You can always change your treatment later on, depending on what's going to work well for your quality of life and what you think you can do. Okay. And I feel like that gives a lot of pressure off for what decision you have to make. Because really the decision that you got to make is what's going to work for you in like the short foreseeable future. And we can always change it later on. Okay. Doing an elimination diet requires a lot of thinking as to whether that's going to work for you. And that can be really challenging for younger patients who are going to school, going off to college, and may need to go to the cafeteria. It can also be challenging for some adults who travel a lot for work. And so then they're really limited as to what they can control for their diet. It can also just be challenging because you're like, I have this one patient who her trigger is shellfish. And every year their family does a seafood boil. And that's she's like, I can give up seafood and shellfish, but just once a year, it would be nice if I could participate in this big family event. Wow. So, you talk with your doctor. Personally, for me in my practice, I feel comfortable giving patients a short course of a topical corticosteroid for once or twice a year where they want to cheat, not said in a mean way, right? Like, it's totally reasonable if you want to be able to take like a holiday from your elimination diet. But I tell them that if they're thinking that they want to take a holiday more than once or twice a year, it just may not be a sustainable option for them. And we should look at other treatment.
No, this is great. We don't want patients to ever feel like this is like the end of the world, that there are ways you could work around this collaboratively with your healthcare provider to find the right solution for you and your situation. The other question that comes up with patients is, like, how do I talk to especially with younger teenagers, young adults, how do I talk to my family and friends about my condition? It's so embarrassing. Like, I can't eat this. And they think I'm just being either they think I have some issues with food, or they think I'm just a drama queen. Like, what do you tell your patients in those situations?
I think it's easier said than done, but, just kind of reassure them that, it's nothing to be embarrassed about, that it's something that they should hopefully feel comfortable talking about with their friends or their family, and just kind of saying, I have an allergy, like I can't have that. No, it's not a classic anaphylactic allergy where you're going to get a rash, that your throat is going to close up. But it is an allergy in that it causes significant symptoms and long-term effects. I would liken it a lot to celiac disease, where you can't have gluten. So it's, in some ways a little bit similar to that. Again, it can be one of those things of if you need a holiday once or twice a year, maybe that's reasonable. Or maybe it's just not going to be a great option for you. If it's going to be hard to avoid things because of friends, because of family, and you're going to want to be joining in on that, there's no shame in saying an elimination diet is not something that's going to be feasible for you. That's okay too.
Yeah, no, this is great. And now, before we wrap this up, I do want to bring in, you kind of touched on it a little bit, but the importance of multidisciplinary care. Getting diagnosed with any chronic illness, is a shock at first, and managing it and so you can live and thrive. And you'll hear that in our next episodes with Dr. Gabbard and Dr. Patel, which are so empowering as well. What should patients know about the multidisciplinary care that they could, have access to, especially at an institution like yours, where there may be dietitians, behavioral health experts who can kind of help them? And can you just talk a little bit about the importance of that, and for patients not to be afraid to seek those kind of alternative experts for their care?
Absolutely. I can't speak for every place, but I can, speak for, what I do in my own clinic. So, Dr. Patel and I have a transition clinic to help our pediatric EoE patients transition from the pediatric side to the adult side. That way they get to meet me in their, normal Peds Children's Hospital clinic for their last visit with Dr. Patel. And then they, come over and see me on the adult side for the next visit. And then that way there's nice communication between the two of us in terms of, what has the patient already done in terms of treatment? What is the current status? What are their symptoms? And they don't feel like there's any loss of information when we transition care. And it's also nice that they've gotten to meet me before they have to come over to the adult side. I promise it's not scary on the adult side. It's just different. And then in terms of other multidisciplinary care, I work very closely with a dietitian. And you should definitely feel free to ask for a referral from, any doctor that you work with. They may have a particular name that they would recommend, or they may say, absolutely, talk with your insurance company and, see who they may cover. But yes, I work very closely with a dietitian, which is really nice because I get 30, 40 minutes to talk with the patient. And by the time I've done my, big counseling session with them, there isn't that much time to go through an in-depth diary on what they eat and what they can eat. I do have handouts that I give, but it's really nice for them to be able to spend an hour and a half with the dietitian to really review, what they like to eat on a daily basis. What are the things that they should avoid? What are good substitutes? And, we have regular meetings to kind of, review how we counsel patients, what the most up-to-date data is, and how we can help them. Other multidisciplinary care, would be, for example, I work with a GI psychologist here. It's not uncommon, and to not be embarrassed by this, that food impactions and having difficulty with swallowing can be really scary and then can result in some fear of swallowing afterwards. That's unfortunately can be a normal consequence of that symptom. Okay. And so, after we get the inflammation under control, if there was any scarring, if we need to do a stretching, we didn't really get to talk about the stretching too much during treatment. It doesn't do anything to control the underlying inflammation, but if there's any scarring, we sometimes need to help stretch open the esophagus during an upper endoscopy. But, after we've gotten all of that under control, a patient may still have some fear of swallowing. And then sometimes working with the psychologist who is especially trained in swallowing and gastrointestinal diseases can be helpful. So that's another avenue that is sometimes gone down. And then an allergist. So again, some patients may have eczema, asthma, food allergies, seasonal allergies, and sometimes the food allergies aren't what trigger their EoE, which can then make an elimination diet even more tricky, right? If you're adding more foods to take out in addition to what food allergies they already have. But, I work closely with the allergist here so that, if they need, immunotherapy shots, something that we can get them feeling better from that perspective as well.
Well, this has been so empowering. In summary, just talk about briefly, because I really want to encourage patients to seek help, to not be afraid, to not fear this. Talk about some of the successful patients that you've seen in general, and that, how this can be easily managed with some due diligence.
Absolutely. I do think it's, it can be scary to be given a diagnosis. It's also really empowering because then you can start to make yourself feel better and take control of what's going on in your life. You're the boss as the patient. You get to kind of pick what treatment is going to work for you and work with your doctor on that. I have so many patients where, yes, they feel so much better afterwards. We get their eosinophils under control. We do any stretching that they need. And then they touch base with me once a year and they're feeling fantastic. Sometimes they need a little bit of a touch up, but they're doing really, really well. And I also just want to say, it's a really new and exciting field, eosinophilic esophagitis. And I do encourage you to always stay in touch with some gastroenterologist who manages it, because things change. change, and it can change pretty rapidly. So, dupilumab was recently approved, in the last few months, right? That's a new exciting treatment that we can offer some patients. So there's always going to be something new. And as long as you're in touch with your doctor, they'll be able to update you on things that are happening.
Well, this has been so great. I'm so excited for our patients to listen to this episode, as well as the other 3 in the series. This is wonderful. So thank you so much, Dr. Beveridge, and we look forward to following up with you. And hopefully if there's any new develops, we can enhance our webinar series. So thank you so much.
Absolutely. Thank you for having me.